Welcome back to the Living Diabetes podcast. I am your host, and today we are diving into another exciting pipeline medication that could reshape how we manage obesity and type 2 diabetes. It is called Amycretin, and it comes from the same company behind Ozempic and CagriSema, Novo Nordisk. Now, in our last episode, we talked about CagriSema, which combines semaglutide with an amylin analog in a weekly injection. Amycretin takes a completely different approach. It is an oral medication, a pill, and that alone makes it stand out. Because if there is one thing patients consistently tell us, it is that they would prefer a pill over an injection if it works just as well. So what exactly is amycretin? It is a single molecule that activates two receptors simultaneously. It targets both GLP-1 receptors and amylin receptors. This is different from CagriSema, which combines two separate drugs. Amycretin is one molecule doing the work of two. Think of it as a dual-action pill rather than a dual-drug injection. The GLP-1 component works the way you already know. It increases insulin secretion, suppresses glucagon, slows gastric emptying, and reduces appetite. The amylin component adds to that by further slowing how quickly food moves through your digestive system and sending additional fullness signals to your brain. Together, these two pathways create a more powerful effect on blood sugar control and body weight than either pathway alone. What makes amycretin particularly interesting is the early clinical trial data. In phase 1 and phase 2 trials, participants taking amycretin lost approximately 13% of their body weight over just 12 weeks. To put that in perspective, that rate of weight loss is comparable to what we see with injectable semaglutide over a much longer treatment period. If these results hold in larger trials, amycretin could deliver injection-level efficacy in a once-daily pill. Now, let us be clear about where we are in the development process. Amycretin is still in early to mid-stage clinical trials. Phase 3 trials are underway, and these are the large-scale studies that will determine whether the drug gets regulatory approval. Phase 3 results are expected in the coming years, and approval, if it happens, would follow after that. So we are not talking about something you can get next month. But there are several reasons why this matters right now. First, the oral route of administration addresses one of the biggest barriers to GLP-1 therapy. Many patients are reluctant to start injectable medications. An effective pill could bring the benefits of GLP-1 treatment to millions of people who would otherwise avoid it. Second, the dual mechanism in a single molecule is an elegant approach. Rather than needing two separate drugs or a combination injection, amycretin delivers both actions in one pill. This simplifies treatment and potentially reduces manufacturing complexity, which could eventually affect cost and availability. Third, the weight loss results from early trials are genuinely impressive for an oral medication. We already have oral semaglutide, marketed as Rybelsus, but its weight loss effects are more modest compared to the injectable form. Amycretin appears to close that gap significantly. What about side effects? The profile is similar to what we see with GLP-1 medications generally. Nausea is the most commonly reported side effect, along with other gastrointestinal symptoms like vomiting and diarrhea. Most of these are mild to moderate and tend to improve over time. The oral formulation does mean the drug passes through the digestive system, which can sometimes lead to more localized gastrointestinal effects compared to injections, but the early data suggests the tolerability is manageable. One important consideration is how amycretin needs to be taken. Like oral semaglutide, it likely requires specific dosing conditions, such as taking it on an empty stomach with a small amount of water and waiting before eating. This is because peptide-based medications are sensitive to stomach acid and food, which can reduce absorption. The exact dosing instructions will become clearer as trials progress. So where does amycretin fit in the evolving landscape of diabetes and obesity medications? We are seeing a clear trend. The field is moving from single-target treatments to multi-target approaches. Tirzepatide targets GLP-1 and GIP. CagriSema targets GLP-1 and amylin through two drugs. Amycretin targets GLP-1 and amylin through one molecule. And there are triple agonists like retatrutide in development that target three receptors. The competition is good for patients. More options mean more choices, potentially lower costs over time, and better matching of treatments to individual needs. Some patients will prefer a weekly injection. Others will want a daily pill. Having both available with similar efficacy would be a significant advance. The bottom line is this. Amycretin represents a potentially important step forward, particularly because it could bring powerful dual receptor therapy into pill form. The early data is promising, but we need phase 3 results to confirm efficacy and safety in larger populations. Keep this one on your radar. As always, medication decisions should be made with your doctor based on your individual health profile. Follow us on social media for daily updates and more content. Until next time, take care of yourselves.